Hello nurses, this is Kevin with nursingkamp.com, and these are my scribble notes on nursing in the NCLEX. And this is my pulmonary lecture number 5, breathing together, putting it together. And we're going to cover everything that we've been kind of talking about in the previous lectures and put it all together. And I'll cover from the sticky note found on Nursing Camp social media, and let's get into it. Okay, so when a nurse walks into the room, and the first question the nurse asks is, are they breathing or are they not? And when we're looking at that principle, are they breathing or are they not? And what we're really doing is we're assessing. Okay? And there's two questions that we're asking when we walk into the room. Is that if they're breathing, what does the patient look like? Which is assessment. And if we walk into the room and they're not breathing, do they have a pulse? And if there are no pulse, we are the pulse, and that is CPR. Okay? But we're not talking about not breathing. We're talking about the patient is breathing. And the first question is, well, how well are they breathing? And that is assessment. And let's get into that. Okay, so we covered several topics so far. We covered the types of breathing. We talked about respiratory rate. We talked about pulse ox. Okay. So the first thing is whenever we come to a question, and we come to an NCLEX style question, what's in the question? Do we have respiratory rate? Do we know the respiratory rate? Well, based on that respiratory rate, where is it? And we talked about that. 16 to 24, that's a normal findings. So is that respiratory rate validate in any of our previous data in an NCLEX question? But if we have an NCLEX question and it's greater than 24, that's acute. And that requires us to look at the patient. And is there a level of consciousness there? What do they look like? We're going to either put them in high follows position, we're going to assess vital signs, more importantly, pulse oximetry. Because if they're greater than 24, they're tachypnic. And that was in our previous lecture on terms. So if we have a change of this respiration and it's elevated, and it's anywhere greater than 24, that is a tachypnic patient. We need to assess the vital signs, put them high follows, and assess their pulse oximetry. And hopefully it's greater than 96%. So if it's greater than 96% and they're greater than 24, what else is going on with the patient? Are they anxious? A normal finding. Are they stressed? Are they in pain? Or were they just exercising, moving around? So always, always, always assess the patient. Okay, the next one we talked about is pulse oximetry. Now, pulse oximetry, I walk into the room and they're breathing or not. Well, they're having difficulty breathing. Okay, well, how do I know they're having difficulty breathing? I might have a term like tachypnic or bradypneic or apneic or Shane-Stokes or Kussmaul respirations. All terminology saying that the patient is short of breath or there's a change of breathing. Now, shortness of breath requires assessment. And we talked about assessment in regards to the lungs. And we said that the lungs are going to have different terminology. So if I walk into the room and the patient is short of breath, I assess. What do I assess? Lung sounds. And I'm looking for data. I'm either going to have diminished. We said diminished patients will generally need antibiotics. They might need some turn, cough, deep breathing, but that might be too late. Because turn, cough, deep breathing is good for rhonchi and rales. We might hear crackles, and crackles could come from COPD patients, and also, more importantly, when we see crackles, we generally will see those with CHF patients. And CHF patients is a cardiac patient, and they would need diuretics. Or we might hear asthma. How do we hear asthma? We hear wheezes. And treatment for wheezes are bronchodilators. So that's another assessment. So assessment is, what are the lung sounds? And we talked about vesicular down here, broncho-vesicular up here, and bronchial sounds of the bronchial tree. Striders up here, wheezes are here, bronchi and crackles, then diminished at the bases. If we have absent sounds, upper is always acute. And that could either be a pneumothorax or a hemothorax. Okay. The next thing is pulse oximetry. So we went through the respiratory rate, we went through the specific terms. We also worked about the assessment in those terms. Now we have pulse oximetry. Now pulse oximetry can be, what we said was 3H cards. And 3H cards is hypovolemia. These are all factors that will affect this oxygen saturation. And if it's just less than 96%, we want to assess these things. 3H cards. Okay? Hypovolemia, that's an assessment. Fluid, hypotension, hypothermia, carbon monoxide, anemia, Raynaud's disease, and dark pigmentation. So we always want to assess the patient because this less than 96% might not mean it's acute if these issues are in play. So that requires us assessment first. But what if we don't have these? None of these are here. Well, if we have none of these are here and we have a low, less than 96%, well, what's the patient's history? Are they a COPD patient? And we'll talk a little bit more about that in the COPD lecture. But we said that there are some terms. So 90 to 95 is always acute. It needs assessment of the patient. You stay with the patient. If the patient is decreased level of consciousness, that's acute. If they're in distress, which is sweating, diaphoretic, that's acute. Call the doctor. Less than 90 is always, always, always acute, unless it's not on their finger. And less than 85, the doctor should be there. The rapid response, the boat is here. There's a big problem going on. This patient is going to lose their ability to maintain respiratory drive. And that's the carboxyhemoglobin curve in another lecture where the point of no return. And this is what this is, a carboxyhemoglobin curve. And what this is saturations. It starts at 99%, 95, 98. And then the interesting thing is about here at 90. At 90%, that's why 90 is such a big deal, because at 90%, they start to go down the toilet really fast. So they drop 85, 80, and they start to really go down. That's why we focus so much on this 90%. And that's another lecture altogether. But that's the basic thing of the carboxyhemoglobin curve. That's why they always say 90% is the most acute, because after 90%, if you don't do something, they will start to decompensate if there's no interventions in place. All right, that's about it. So that's my basic overview of breathing and the assessment of the patient, and lung sounds and breathing terminology and vital signs of respirations and pulse oximetry. Based on this assessment sheet and found on nursingkamp.com and social media. I'm going to start getting into the pathophysiology and more of oxygen delivery devices in my next lectures. So we'll see you next time in Nurse On.